pneumonia more than they were up front. But up front, that's what we were being told. And we also knew that any virus is going to spread within congregate settings. And as folks with intellectual and developmental disability disproportionately live in congregate settings, we knew that would be also cause for concern. There was very little data up front. There was the one report in the New York Times. And then there were also some reports, Ari Neiman at Harvard and Brandeis was talking about the possibility of discriminatory triage if it came to that, with triaging ventilators, with the folks with disability have equal access. But beyond that, there was very little empirical evidence for differences in COVID outcomes. Our suspicion, though, is because of being a vulnerable health population, having higher prevalence of comorbidities, that we'd see disproportionate and more severe outcomes. And so what we highlighted early on was some of our earlier work where we've looked at cause of death trends for folks with and without intellectual disability. And that's what I've got charted here at the bottom. Where this one is looking at, this is prior to COVID, obviously, but looking at death from pneumonia. So pneumonia-related deaths in the US. And what we knew from these earlier studies is that this population of folks with intellectual and developmental disabilities are much more likely to die from things like pneumonia, from pneumonitis, which is more long-term chronic lung infection, than the general population. And so these were kind of the red flags for us going into our studies on COVID for this population, and kind of what set the stage of us having the most concern for what we would be seeing. Our first study was with what's called Trinetics analysis. Trinetics is a database of real-time electronic medical records that SUNY Upstate participates in, as well as multiple research hospitals in the US, primarily in the US, but some internationally as well. And so we were able to look at data early in the pandemic through May 14th. And to look specifically at people who had been diagnosed with COVID-19 by a physician or test result. And so we excluded other viral diagnoses or people who had suspected. And we really, this first study, we focused primarily or only on folks who had a physician or lab test confirmed diagnosis of COVID-19. We were able to pull out within the medical record using ICD-10 codes, different diagnoses for intellectual and developmental disability, for ID, for CP, for Down syndrome. And so up front, we had about 30,000 cases of real-time medical records. And of those, 474 were people who had intellectual and developmental disability. What we saw in this early study were two things. The first was higher rates, higher prevalence of comorbidities that we were being told were associated with more severe COVID outcomes. And you can see this down here. I've got this broken down by age bands, 0 to 17, 18 to 74, and 75 and older. But in every age band, looking at respiratory diseases, endocrine, nutritional, metabolic diseases, and circulatory diseases, the percent of patients within this database with IDD who had these coexisting conditions or pre-existing conditions was higher across the board. And so this kind of confirmed our suspicion going in, is that this would be a more susceptible population to COVID due to higher rates of pre-existing conditions. And then we were able to look at case fatality rates to compare those with and without intellectual disability. If you look at everybody together, the case fatality rate, so case fatality rate being, what you do is you calculate the number, it's calculated by having the number of people who have died from COVID-19 and divide that by the number of people diagnosed with COVID-19. So it gives you just a raw percentage rate of the percentage of people who have been diagnosed with the illness actually die from it. And there were similar rates of death from COVID-19 between those with and without IDD in this database of medical records, around 5.1 to 5.4%. But what was really interesting is when you broke it out by age bands, you saw some differential rates. For those 75 years and older, we had very similar rates, 21.1 among those with IDD and 20.7 for those without IDD of case fatality from COVID-19, which this makes sense if you think about heterogeneity of frailty, that as populations age, those that are more frail within the population die at younger ages. And so by the time you get to older age, you really have the hardiest people, either with or without intellectual and developmental disability. Those people who have survived the longest typically have had the best health. And so we see similar outcomes of case fatality 75 and older. this is confirmatory of prior studies looking at other respiratory-related outcomes and mortality risks for those with intellectual and developmental disabilities, and showing that risk factors past age 75 typically plane out and become really similar to the population. But what was interesting about this study is we found higher case fatality rates at younger ages. So for those 18 to 74, the case fatality was 4.5 compared to 2.7 without IDD. And for those 0 to 17, it was 1.6 to 0.1. So our conclusion from this study was that there was more risk of more severe COVID outcomes for folks with intellectual and developmental disability, but only among those of younger ages, up through age 74. So with this in mind, we began working in around late March, early April with NIDA, with the New York Disability Advocates. And so Bill DeVoe and Mike Alvaro from CP State have worked with us on this. And before I even came along, NIDA, as many of you know, and many of you have participated in this, began collecting data from providers associated with this organization. And I just want to put my plug in here to thank you all. I don't get to directly meet many of the providers. I just get the data on the back end. But for those of you who have participated in the NIDA survey and are continuing to do so, you really are driving research on IDD outcomes for folks during the pandemic. To date, there are only 3 studies that show empirical evidence on COVID outcomes for folks with 3 published studies with IDD. And one of those is the NIDA study. And so you really are making a difference in helping us to better understand what's going on within this population. So NIDA began collecting their data. We've tracked the data through, I just actually worked on the data for this week, through currently, and we'll continue to do so. We're looking at about 67 providers within the NIDA organization, represents about 13,200 people with IDD living in residential group homes. And this is about 35% of the total state population, the New York State population. And we'll continue to do this at least through the end of the year, maybe longer, depending on what goes on with vaccine and flu season and things like that. So I want to show you a few things. I want to show you case rates. Case rates help us to understand the spread of a disease within the population. And so I'm going to compare the case rates among the residential group homes that we're surveying to New York State overall. And so we'll be able to see the growth in the cases over time. So I'll show you the case rates, the case growth rate, and then we'll look to death from COVID. So we'll look at case fatality rate, which is how many people who have been diagnosed with the disease actually die from it. And then the last thing I'll look at from the NIDA data is the mortality rate, which gives us an idea of, among the entire population, how many people are dying from COVID. So the first thing is the case rate. And like I said, this is tracking over time. So from April 10, the last data that I have in this slide is through 25 of September. And this shows the growth in cases. And this is calculated as the number of people who have been diagnosed with COVID divided by the population. So it's the capacity within the group homes. And then you multiply that for public health data by 100,000. So these rates are how many people have been diagnosed with COVID per 100,000 people in a population. That's just the basic comparisons that public health studies do. The blue line is within the residential group homes. The orange line is New York State overall. And so what we see is up front, there was a much more substantial growth in the case rates among the residential group homes through around early May. But then around early to mid-May, we see it to start to plane off. And so the differential rate in growth that was so severe early on starts to plane off around early May. And let me just show you, this is why I wanted to keep it off of the slides. It's easier to see this if you convert this to a logarithmic graph, which takes away the difference in volume of cases, but just really shows you growth patterns. And so what you see is early on, like I was saying, through early May, it's a bit of a differential growth pattern. You see more growth among the IDD residential group home population, but by the time you hit mid-May, these are really almost parallel lines. And so the rate of growth, once past this initial surge, where it was so much worse among the IDD population, it's really been, the plateaus have been similar. since mid-May. We're not seeing spikes among the IDD residential group homes like we saw in the early part of the pandemic. And what backs that up is if you look at case growth rates. And so case growth rates are week-on-week growth rate. What is the percentage growth in cases? Like if you had, 50 cases this week, how many cases do you, so you go to 100 cases next week, you've doubled the amount of cases. And so this is looking at the percentage of growth over time. Again, the blue line is within the group homes, the residential group homes in New York State. The orange line, again, is New York State overall. And we see the similar pattern. You had higher case growth rates among those in residential group homes from mid-April through mid-May. But by the time you hit mid-May, the case growth rates are very similar, sometimes even lower. The blue line is actually dipping below the state. And so something's shifting. And this is where I think Vincent and Jim can get more into this to talk about some of the policies that were put in place by the homes and also by the state, because I can't with the data tell you exactly what happened, but I can tell you something substantial occurred by mid-May, where before mid-May, we were seeing much greater growth rates among the residential group homes. By mid-May, it comes in line to the point that's actually ducking under or staying similar to what we see in the remainder of the state through, and this is going through current. I've got this through 25 September. I was just looking at the data earlier. It is staying very similar even through now. So let me turn to case fatality rates. So again, this is among those who have been diagnosed with COVID-19, the percentage of people, just a raw percent, that have actually died from the disease. And we see something a little similar where early on, in early to mid-April, the case fatality rate from COVID-19 was trending 20 to 19%. A little bit lower, that was lower in the state, around 6.5 to 7%. And you see the different directions here, where the case fatality rate among the IDD residential group home dropped by late April, where it did more of an increase among the state. And then from that period going forward, you have really similar trends in the lines. Again, if you go to a logarithmic graph, you'll see this a little bit better, where it's very similar trend lines. You see little tiny bumps in the IDD population from time to time, but they're not substantial and they almost immediately go back down. And so again, what we're seeing is that early on, the case, now this is not to disguise the fact that you've got a much higher case fatality rate among the residential group homes, which is what we would suspect because they are congregate settings with a much more vulnerable health population. And so you do have a differential. It's about 1.8 to 2 times higher case fatality rate. But what I want to stress here is it's actually trended very similarly to what we see in the state since about mid to late April. And then the last slide from the NIDA data that I want to show you is the overall mortality rates. And so where this is a little different is this is calculating not the percentage or number of people who have died, who have been diagnosed with COVID, but the number of people who have died in the overall population. And again, you see much higher and much more substantial growth in the mortality rate early on through early May. I'll take this to logarithmic so you can see the trends again. But once you get to early May, going through current time period, end of September, and like I said, I've traced these through October, we're seeing very similar patterns in the overall mortality rate. So all three of these, if you look at the case rate, if you look at the case fatality rate, if you look at the case mortality, or the mortality rate, they're telling a very similar story that early in the pandemic, through mid to late April, early May, the spread of the virus seems to be worse in the group homes, and deaths from the virus were at a much substantially higher rate. But both have come into line. Now, the case growth rate is very similar. The case fatality rate stays higher, but the changes in it over time are very similar to what we're seeing in the state, which in my mind says something shifted by late April, early May in the way that the IDD providers were able to address the pandemic within the homes. And actually, in a lot of ways, I don't know if we could say this ever about COVID, but it looks like from the data that things kind of got under a little more control, that maybe their system came into place where the providers and the direct service providers had the resources needed to actually make sure they could do their job despite early on where there were shortages of PPE and things like that. The last thing I want to show you, and then I'm going to pass this on to Vincent and Jim to give you more on the ground discussion of what actually they were able to do to help address what we were seeing in the group homes with this data. We're starting to look beyond New York, and we started to look at some California data. The question that we've had is this just about IDD, or is this really more about the type of residence, where people are living, that's driving the higher rates? Because we're seeing some reporting from some other states across the nation that are showing similar case fatality rate differences, where people with IDD across the board seem to be about 1.8 to 2.5 times more, have higher case fatality rates of 1.8 to 2.5 times more. And so like if you've got a state there that got a really low case fatality rate of 2%, we're consistently saying in that state that the IDD case fatality rate will be 4%. A state has 7, it's going to be around 14. So it's about close to about double across all states. But this is data from California. And California as a state is reporting all cases and deaths from COVID for everybody served within the state, but they're reporting by type of service. And we were able to group the types of service into where people were living. And so the overall, this is for those without IDD in California. The overall case fatality rate in California is about 1.9 to 2%. And if you look at everybody with IDD receiving services in California, it's trending about 6%, so about 3 times higher in that state. But there's some real differences by where people are living. If people live in their family home or their own home, this is the bar right here, it's about 3.5 to 4% case fatality rate. So a little higher than the state, but really not much. If they're living in a community group home, not an ICF, but just a community group home, it's trending around 5%. Where you see the real differences are 2 things. Either they're living in a congregate setting with more than 15 people, and that's where you have in these 4 categories over here. You've got 15 or more people. And so you see the case fatality rate bump up a little bit in these ICFs. But where it gets really bad and what is skewing, in my mind, and bumping up the overall case fatality rate so high is it's people living in ICFs that are receiving 24-hour nursing care, which makes sense. These are the people with the highest level of medical need. And so what this study is showing us, and this one will be coming out in within the next couple of weeks or so, is yes, people with IDD across the nation are not faring as well during COVID-19, but it does seem to be a combination of where they're living. Are they living in a congregate setting, or are they living in a family home? But more particularly, the type of pre-existing health conditions and needs that they had prior to the pandemic seem to be greatly informing what's going on here. So I will stop and turn this over to Vincent and Jim and let them talk more about what they've been doing over the past few months to deal with this on the ground. Thank you all.
Thank you, Scott. So good afternoon, everybody. My name is Dr. Vincent Siusoko. I'm a family physician. I've been practicing for over 15 years here in New York City, working with patients with DD. For this part of the presentation, I'm going to be giving some insight from the health center end and how we were able to continue providing healthcare from a distance during the height of the pandemic and will be into the near future. Jim, next. Can I ask Jim to help me out with this? So the Metro Community Health Centers are a network of federally qualified health centers throughout New York City. We provide services across the age span to patients with DD, for those that live in the community, and congregate settings from over 40 DD agencies in the area. We provide primary care, gynecology, psychiatry, psychotherapy, dental, neurology, podiatry, and optometry. In addition to our office hours, we have an after-hours on-call service. We provide services to almost 5,000 patients in the area. We generate close to 60 to 65,000 visits a year. We're what's called an NCQA recognized patient-centered medical home. Next. So 7 months ago, seems like a real it seems like a lifetime ago. All of us have been through a lot, and unfortunately, it's still here. As we recall, back on March 7th, the state of emergency was declared in New York. March 11th, COVID-19 was declared a pandemic by the World Health Organization. On March 16th, New York City's public school system, the nation's largest, closed down to COVID. And then on March 17th, OPWDD suspended services at all day rehabilitation and day treatment programs. That Tuesday of March 17th was just an overwhelming situation for all of us. It was the first time that in all my years of working at a health center and clinic that there was nobody in the waiting room. There was no one expected to be seen. We were all kind of just wondering what was going on, what could we do? Of course, during that time, there was a fear and uncertainty of the coronavirus. What's outside? Can we go? What do we need to do? Every 10, 15 minutes, it seemed like there was always something coming up on the news. As a physician and our health center as a whole, we all felt hopeless because we were now cut off from our patients and they from us. These were patients that we were expecting to see for their diabetes, their hypertension, abnormal lab results, their cancer screening tests. Maybe some were needed to be seen for behavioral issues or having their psychotropic medications adjusted. So it was a real challenge to come, having been cut off from everybody and vice versa. So the immediate challenge and the question for us at that time was, as a family, as a federally qualified health center, different boroughs, how do we continue to provide health center from a distance in the face of a pandemic and do it safely and efficiently? The next slide. So fortunately, we had some systems in place already that helped us get started. We were a patient-centered medical home. We already followed the model of care. We were utilizing the Regional Health Information Organization information that we put together a year before. But we also had a great team that was able to also step up and implement new systems that we've never had before. This includes telehealth services, providing chronic care management services, and also starting annual wellness visits. Next slide, Jim. So as I said, fortunately, we already had established systems in place. The Metro Community Health Centers were already a recognized patient-centered medical home. A patient-centered medical home is a model of care developed in 2007 by the American Academy of Pediatrics, American Academy of Family Physicians, American College of Physicians, and American Osteopathic Association. It's basically a model of care that ensures that care for the patient, for the individual, is well coordinated, comprehensive, and continuous. It was important that we had this in place to ensure that we could provide the services. Patient-centered medical home, it's a term that's used pretty widely, but the NCQA, National Committee for Quality Assurance, is the governing committee that establishes this model of care and places the recognition and gives the recognition to different health centers across the country. This recognition they have very strict criteria, and on a yearly basis, we have to basically reapply for recognition just to ensure that we are abiding by what the model of care requires us to. So some aspects of being a patient in a medical home really helped us get set for what was to come. One was patient-staff experience. Patient experience is very important as a patient in a medical home, as well as staff feedback. Thus, communication and coordination was crucial during the initial days and weeks of the pandemic. This meant us having morning huddles and debrief meetings with staff, from the front desk staff, from the nursing staff, from the physicians and the clinicians, whether they were on site or working at home. We all did this by all Zoom meetings or by phones. We wanted to make sure that we were getting feedback almost on an hourly basis, if not every few minutes. We wanted to make sure that what we were doing was correct. This was all new to us. Of course, the pandemic was new, but as you'll hear in a little bit, So was telehealth, and this was what was key for helping us move forward. So these huddles and debrief meetings were key just for ensuring communication. Again, as a patient in a medical home, what also is key is monitoring quality measures in high-risk groups. So when you talk about monitoring quality measures in high-risk groups, this includes monitoring those who are diabetic, those who are hypertensive, those that are at risk for going to the emergency room. What we also did was we also tracked external referrals. External referrals pertains to those labs that were ordered on our individuals, diagnostic tests that were ordered that may have been done on the outside, DEXA scan, X-rays, ultrasound, so on and so forth, and specialty care. If we had to refer outside to a gynecologist, an orthopedic surgeon, or an endocrinologist for services that we couldn't provide on site. One of the systems we had in place was we were able to track the referrals as best we could. For example, for those labs, we were able to track retrospectively those patients with abnormal lab results through Quest Diagnostics. So we're able to look back to see which of our diabetic patients, for example, were uncontrolled, had a hemoglobin A1C over 8 or 9. So we could make sure that even though we couldn't see them on site, we could set them up for a telehealth visit and follow them. If we knew somebody had to come back in because they had to get their psychotropic medications adjusted or new medications was being started, even though we couldn't see them on site, we were able to set them up with a telehealth visit. We were also able to identify those patients that needed to see specialists. For example, we were able to identify, for example, somebody that maybe had a positive colon cancer screening test that was done on site at an annual exam, and they were scheduled to get a colonoscopy done. So unfortunately, all elective procedures were put on hold. However, what we did was we wanted to make sure that we did have a list so that when the time came to start seeing patients, we knew who was the priority and who wasn't. So what we did was we actually identified about 4 or 5 patients that were waiting to get a colonoscopy based on a positive lab result from Quest. So, unfortunately, hospitals, specialists started opening up their clinics, and they were on our priority list to get those set up. Emergency department utilization, transitions of care. We have been doing this prior to the pandemic, making sure that we don't send any individuals to the ED for unwarranted reasons. We didn't want to send anybody there prior to the COVID and even during the pandemic. So we always monitored our patients that we transferred to the ED during office hours and after office hours. So another way we were able to monitor this, in addition to just getting feedback from our doctors who are on call for us, was also through the Regional Health Information Organization. Jim, if you could go to the next slide. So the Regional Health Information Organization, or RIO, is an exchange organization that facilitates sharing of patient information among hospitals and providers throughout New York City electronically. The RIO we connected with is called Healthix. In partnering with Azara Healthcare, which is another entity, we utilize the data platform to put together this transitions of care report. The way the Healthix works is that, fortunately, we didn't have to ask for a consent from a legal guardian or mom or dad. It was anybody that went to the ED or was hospitalized and they were identified as one of our patients. We were able to get what was called a clinical event notification. And the clinical event notification is very bare minimum information: patient name, date of birth, name of the hospital, when they were admitted, and when they were discharged. But this was enough to give us enough information to identify where our patients were. With the Azara Healthcare platform, we're able to bring it to the next level and also include what was the next appointments, what was the patient's next appointment scheduled for, what was the date, and all the other information around the health center. So for example, as you can see here, you may see a patient here that was admitted to Jacobi Hospital on September 17th, discharged on September 21st. You'll see that their next appointment was on the 23rd with myself. So what we saw here, especially during the times of the pandemic, obviously, unless we send the individual to the ED ourselves through our physicians during the day or after hours on call service, we always wouldn't know who was sent to the ED or who was hospitalized. That was kind of, unfortunately, things were happening so quickly. But by using this electronic data, we're able to see who was being sent and who was being discharged. And what was key is who was being discharged and when the next appointment was. So what you would see here is that you would see appointments. What we would see are appointments that were scheduled maybe 3 or 6 months prior to the pandemic even occurring. So you would see the next appointment maybe being on April 2nd with podiatry, or there was no follow-up appointment with the primary. So we're able to identify who was seen in the ED, who was discharged, what was their next appointment, and who was it with. If it wasn't with a primary care provider or a psychiatrist or a neurologist, we were able to set up those appointments and make sure that each one of them had a telehealth visit. So basically, this transition of care report really gave us a 30,000-foot view in which we were able to see all of our patients from a distance where they were at. So even though we couldn't connect with the nursing director, the DSP, or mom and dad in the South Bronx or Brooklyn, we kind of had an idea of where everybody was being seen, fortunately or unfortunately. One of the things here that you can also see is that what's nice about this report is that we actually were able to do a look back of the last 6 months for any ED visits. So even though we couldn't always get the diagnosis, we couldn't always tell if somebody was seen at Jacobi for COVID, or was it for constipation, was it for a behavioral issue. But what we were able to glean is that if John Smith maybe had 30 visits in the last 6 months for an ED visit, it was kind of a safe bet that it was probably for a behavioral issue, as opposed to, say, an infectious process, chest pain, passing out. So this report was really key, again, to give us this very high level view to see where all of our patients were, even though we couldn't communicate directly with the patient's families or the nurses or the DSPs in the group homes. It enabled us to be proactive and make sure that we can follow up on any appointments that needed to be done. And again, all remotely by telehealth. In addition to this, as you'll hear later in another session, we work very closely with another telehealth group, as you know, Station MD. So during this time, we were working closely with them as they deployed their kiosks to the different DD agencies, especially in New York City. So we were providing the primary care. We're working closely with them to also be that support to those individuals, those DSPs, and those nurses in the group homes. So we would set up conference calls with the nursing directors and DSPs and just get on the same page, to show that we both were available to those entities and how they could utilize us in the best way. Next page. So talking about telehealth services, of course, telehealth service is really the big game changer for all. But it's not just New York City, New York, it's just across the country. Telehealth, of course, isn't new. It's been around for a few years, and I think most of us would have loved to provide telehealth services prior to the pandemic. We know that some affiliates, even CP affiliates, and probably I think northern New York, more than rural areas, have been utilizing telehealth for a few years now. So we've always been a big advocate. One of the challenges that we have had is that we are a network of community health centers in the middle of New York City, in an urban area. So unfortunately, we were restricted by state and federal regulations and not being able to provide the telehealth services and get reimbursed in a proper manner. So it was always a big challenge for us. But of course, the pandemic changed everything. And CMS allowed us to provide the telehealth service and get reimbursed appropriately. I think one of the challenges that we had as a telehealth center, as a federally qualified health center, was the fact that we weren't having patients come on site. So we unfortunately had to shut down some of our locations and also unfortunately furlough some of the staff. So with the telehealth services, we were able to provide, which is the priority, quality care, continuous care, and comprehensive care, but make sure that we could also pay the bills and stay open. So when we started getting notices from the CDC and DOH and OPWDD with the pandemic, the state of emergency, with the day programs being closed, we were really faced with the challenges. What do we do? We heard about the grants, we knew about the grants, we knew about different FQHCs providing telehealth services. So March 16th, 17th, we had meetings upon meetings. It was almost 24/7. We were all communicating. And at Metro, it really took not only a village, a town, a city, but it was all of us working together. And within a week, we provided our first telehealth service on March 23rd. It wasn't without its challenges, its bumps, its kinks. It was definitely a work in progress, but it was just kudos to the staff. But it really changed everything. Scott, I know you're talking about the timeline. Um, Everybody had their different challenges, but I think it wasn't perfect, obviously, but at least we were able to reconnect in some way to our patients and follow them and address some of the more urgent issues that needed to be addressed during this time period. And we could do it from a distance, and we didn't have to lose touch with them. So I think, again, the telehealth is just such a game changer, and hopefully it'll be here to stay, as I'm sure it will be. So another system that we had in place was chronic care management services. Chronic care management services is a program through the Centers for Medicare and Medicaid Services, CMS. It provides extra care management for high-risk patients with 2 or more chronic conditions. Services is conducted outside of actually routine and acute office visits. It's actually in between the visits. The way this works is that a care coordinator connects remotely with patients over the phone to develop individualized care plans and provide ongoing support to help patients stay on track with their healthcare goals in between visits, namely telehealth visits, especially during the pandemic. This enhanced level of care allowed Metro to provide more intensive services for some of our highest risk patients, which was critical during this pandemic. One of the criteria to receive these services is that the individual has to have 2 or more chronic conditions. So these care coordinators were able to add a layer of support to those nurses in the group home settings that were already overburdened, as well as the DSPs. They were able to ensure that everybody had a follow-up telehealth visit set, and if they didn't, there was a no-show, the video wasn't working, the kiosk was broken, or what have you, they were able to follow up with the nurses or whoever was the advocate for that individual receiving the CCM services. They were able to make sure that everybody got their medications, their refills. If there was a problem with the phone systems, they were able to get through the care coordinator. So I think the chronic care management service is really very helpful, especially in between visits. So for example, if I saw John Smith on, say, April 1st, and then I wasn't going to see them for maybe another 2 or 3 months, our care coordinators were able to continue communicating with the patient and their caregiver to make sure that they were taking the medications that was prescribed, making sure that nothing needs to be addressed in between the 2 visits. So that's the chronic care management services. Annual wellness visit is another CMS program, which is made with the PCP. We're in the process of rolling this out prior to COVID. Then the pandemic hit, so we had to put it on pause. But just recently we started going back to utilizing it. The annual wellness visit is actually very beneficial. And it's not a head to toe physical, but rather it's a visit based on screening questions. And what's key about the screening questions is it's questions that wouldn't always be answered. For example, at a podiatry visit or a psychiatry visit, it addressed questions that had to do with people's nutrition, for example. This wasn't only for patients that lived in the community, in group home settings, but also those that live in the community. For example, nutrition questions are being asked. How many meals do you have? Are you able to access food? Can you go to the grocery? Home safety issues. Do you feel safe at home, especially in the pandemic? Unfortunately, we are now hearing and seeing issues of behavioral health and just unfortunate concerns that have been happening. So the annual wellness visit evaluates the safety of the individual in their home. Are they in a safe environment? Are there any issues with falls? Are there any fall risks? As you can imagine, during the pandemic, there was no exercise. Nobody was going outside. Patients with cerebral palsy were not getting the PT, the OT that they were getting on a regular basis. So individuals were deconditioned. So fall risk is really something really to monitor. This in addition to health risk, making sure that their mental well-being is there. Are they getting depressed? Are they getting stressed? Are they getting anxious? What happens with these annual wellness visits is that it's a good way to be a red flag, so that if something comes back positive on these screening questionnaires, we can set up a telehealth visit immediately. So for example, there's an issue with depression and new onset stressor, or they can't get their food, or there's an issue with the safety regarding a family member or so on and so forth, we're able to set up an appropriate appointment, be it with a primary care provider, their psychologist or the psychiatrist sooner than later. So those are the annual wellness visits. Jim, next topic. Next slide, please. So the lessons learned. So staff. I can't give credit enough to our staff. And if I could name each and every front desk staff, nurse, medical assistant, physician, clinician, nurse that helped us get through this, I would. But it was a pretty overwhelming experience, but it was also enlightening to see how people can come together and wear different hats and take on more than they ever expected to before. And they were truly the key to us still being here. Us being a patient-centered medical home model of care was key. Having the systems already in place, existing, ways to coordinate the care, communicate, follow up on referrals, making sure our high-risk group patients are being taken care of and monitored closely was key. Communication, again, internal. We were having huddles, debrief meetings, end of day, whether the staff was on-site or off-site, working remotely. External communication, again, CDC alerts, DOH webinars, information from OPWDD. Us communicating with the different DD agencies and vice versa, talking to the medical directors, nursing directors, residential managers, different DD coalitions, and also speaking with the hospitals, the ED doctors, even the urgent care physicians, just to kind of get an idea of where they were at, who could we send our patients to if need be, which ED was overrun, which urgent care center could do a nasal swab, which ones couldn't. So that was all key. Telehealth, again, is a huge game changer, and I'm sure it's going to be here to stay, and I hope it's going to be here to stay. But unfortunately, it's not the be-all, end-all. I think one of the things that we were all concerned about is that there are individuals that will need to be seen on site. I think one of the things that we learned was, I do have to be honest, personally speaking, we were concerned about those that, were due for their cervical cancer screening, breast cancer screening, colon cancer screenings. That's not something you could provide via telehealth. Listening to someone's heart for a murmur or someone's lungs to see if there's any wheezing or abnormal breath sounds, or listening to someone's abdomen for constipation or fecal impaction. So nothing unfortunately takes the place of a hands-on physical exam, but having a hybrid model of care is going to be key to the future of healthcare, especially for our patient population. So the future, again, telehealth regulations, the reimbursement, that's going to be key. Again, patient care quality is at the forefront, but ensuring that we can still provide the services and get proper reimbursement is going to be key. And of course, the vaccines is on everyone's mind. So hopefully it is going to be here sooner than later. But I think also we need to keep in mind is that when the vaccines are available, that our individuals and our frontline staff, DSPs, nurses, are all on the priority list to get those vaccines first. So I think that's it from me. I'm going to hand it off to Dr. Jim Powell at the Long Island Selective Care. Thank you for your time.
So thanks, Scott. Thanks, Vincent. Very excited to be here and share with you. So welcome to the new norm. So here we are, and let's just dive in. I'm going to spend some time not just specifically about what we did as a healthcare organization, although I'll share some stories and some insight, but also about how we collaborated with our partners in the DD agencies and how we kind of worked together to kind of look at some of the struggles that we could overcome together. A little bit about LISH so that you know. We're also a federally qualified health center. We originated from 3 agencies, so UCP Suffolk, DDI, and FREE, and we actually came together in August of 2016. We service almost 7,000 patients, and actually greater than 40% of our patients actually have an IDD diagnosis. So we have a very robust IDD program, and really that is our first love, and one of the things that we're most proud of is being involved with these patients that we share for years and years. DDI and FREE and UCP Suffolk had their health centers for 10, 15, 20 years. So we came together. We had many years of experience. We have 8 offices across Long Island. We're also recognized as a patient-centered medical home, and we'll also provide multiple services: medical, dental, mental health, HAB, and specialty care. And take a step back. So we got involved in telemedicine and virtual care going back to 2014. So from 2014 to 2017, we were part of this BIP grant. So we spent many time, in fact, I was one of the lead providers there, taking care of about 2,000 individuals to prevent them from getting and going to the hospital. So we deploy nurses. We had this expensive, wonderful equipment with stethoscopes, otoscopes. We did, urine testing. We did dipstick for flu and throat cultures. And probably around 2017, I was seeing a patient. He was a 30-year-old autistic gentleman. He had 103 fever, nonverbal. The RN brings the equipment with the stethoscope and the thing, and I have my headset on, and he was engaged by the screen, so he stopped jumping up and down, and I heard the pneumonia, and that was my aha moment of like, wow, this is the power of where healthcare was going. I said, this is what we really need to make happen. So in 2017, I said, okay, let's make this part of everyday care. Well, as you know, nothing changed until recently. So for 3 years, we've been trying to figure out how to make this part of our workflow. So we were fortunate because when we had done the chronic care management program that Vincent had talked about, it allowed us to kind of take advantage of getting some additional services and offset some of the free costs we provided for virtual care. So we actually had budgeted going into 2020 that about 4% of our visits were going to be free telemedicine visits, just so we could prepare for the inevitable. And as you know, you got to be careful what you wish for, because no one expected it to be as dramatic and as quick to come on board. And so when you talk about what have I done personally with virtual care, so I've gone from that visit back in 2017 to now doing video visits, and like many of you and primary providers, you may even be part of these Zoom coasters. And if you don't know what a Zoom coaster is, that's when you log on with the staff and they have to carry you through the house to find the room. So you put your arms up and you go through the house and the hallway looking to find out until you get to the room. And this is kind of how care has kind of evolved for us. So, what should we consider, based on past experience to help us going forward is that, we have to go and realize that we had our old normal. We went from a complete lockdown to a hybrid model of care. And we have to think about where we are now, and are we comfortable with our current staffing, our current workflows, our current ratios, and what are we going to do if and when a new wave occurs? And one of the things I start with is by saying that I talk about in some of my lectures that this concept of triangle of care. And I think this is valuable as we all talk about the partnerships, that the patient obviously is up top, the practitioner is to one side, but just as important in this triangle is the caregivers, the agencies, and the stuff that we support. And when you think about workflows, needs, and outcomes, it is really taking part of all three of those. Now, some of my patients are just myself and the provider because they're independent. They live and they get some supportive services, but many of them that you serve, are dramatic 24-hour care in a significant amount of on-site services. So we need to be mindful of whatever decision we're making, who are we affecting in that triangle of care. And really what's evolved now is this kind of new model of the triangle of care, saying that, well, now we have access to care issues for all of us, the patient, the caregivers, and the patient. We have engagement, again, for everybody, and also fiscal responsibility. So how do we be mindful of the decisions and the workflows and the plans that we're making that doesn't jeopardize what CP State is trying to do? It doesn't jeopardize what the patient's trying to do in terms of their ability to do things and obtain the services and meet their own needs. So it really becomes important for us, again, as we think about how we partner together to look at these in one big complete package for us. So, the rationale for being a hybrid model of care, it becomes more and more important, because if we can consider that, are we going to be at a complete lockdown? Are we going to be complete free and available to do services? What type of services are we provided? So if you keep this mindset that hybrid is part of what your care is going to be, as Vincent had alluded to earlier, it becomes important for us to kind of figure out how we make the next steps. So, we're all past telemedicine 101. We all know how to log on, do our Zoom visits, do our sessions, but you have to look at all the services that are provided and just get beyond what's going on and look at how am I going to receive dental? How am I going to receive medical? How am I going to receive behavioral health and PT and OT and speech, and look at what I'm capable of doing and where we're going to go. one of the things we did back in June was we decided, we want to understand based on Scott's data and what we've seen and reading is how is this affecting us and how is this going to affect maybe decisions we do going forward for the summertime and into the fall, specifically as the flu season went on. So we created 2 partnerships with BioReference and LabCorp, and we offered to all the group homes and the agencies the opportunity that if they wanted to, we will actually order the antibody testing for individuals, do a screening test if they're eligible, looking at the IgG antibody levels for our patients, and just see what did we discover. So we'd offered up to 414 individuals. Some have not actually had the test yet or have canceled the test, but we did get 330 individuals, all within the group home environment. And what was fascinating to me is that 229 were negative, or 69%, but there was 31% positive. And we're going to start combing through that data a little bit more, but not all those individuals had symptoms. And so 31% of the individuals in the group homes were positive for the antibody. Now, what's I think fascinating for us on a clinical end, but also potentially fascinating for the agencies on the support end is it gives us an opportunity to kind of look at, what occurred. We went through this incredible first wave of the pandemic. How did we do? How did we do in terms of staffing? How did we do in terms of PPE supplies? How did we do in terms of our own isolation techniques? And did we do things right? So I feel that we can debate the value of the antibody test and say, well, maybe it wanes in time and it may not be a true predictor of how people are going to do down the road. But I also felt as a partnership with the agencies that we support, if we can all think about that triangle of care and see what can we do better to maximize our success going forward, and having that data I felt was valuable to allow, again, staffing ratios, equipment supplies, where things are and how we make discussions and make decisions based on who's in the house, who was hospitalized, how people came back. I mean, there's been fascinating stories about what the group homes had to do in terms of having plexiglass out front so family members could see each other without touching each other, and complete lockdowns and lighting those up and not letting individuals back to the house and being with the parents. And I had elderly parents who had trouble handling their own children and they weren't allowed to bring them back. So there was a lot of issues that really developed. And although the statistics show that we, quote, did a better job come, the summer and on, did we do a better job with all the variables that we can address? So, I think looking at these statistics kind of really opened my eyes to say, how do we strengthen the partnerships? How do we look at each other to support? And how do we create some opportunity for us to kind of tweak and improve future programs going forward for us? So I think that, the journey for sustainability really is us as a partnership, right? So how do we look at the important things that we need to do? How do we look at patient-centered outcomes? How do we look at value-based programs? How do we look at optimizing revenue, not just for the health centers, but for the agencies that we support? If an individual is not in program, you're not getting paid. The individuals in the hospital, you're not getting paid. So how do we look at creating higher quality patient encounters at lower cost? And this all gets tied into technology. So I think technology is important. I have a feeling that most of us should really be agnostic in our approach, that we don't have to lean on one specific technology, whether it's Zoom or whether it's X or whether it's Y, because we have to have the workflows set up. And all of us, whether it's the health centers themselves or the agencies that we support, the leadership has to be part of the early adopters, because it's part of the motivation, for the mission. Because if you want to be successful, when we're all anticipating cuts in revenue, whether it's for housing, whether it's support, whether it's for programs, how can we create a nimble environment that we can look to modify where things are? Now, I will kind of get on my soapbox and talk about patient-centered medical home. And what I love and hate about it is that, it's supposed to be elevating the patient and put the patient in charge of their health care. But the reality is it's the primary care doc saying, you got to do this, you got to do this, you got to do this. And I think the agencies need to kind of work with us a little bit better about really providing care, and so that we really are elevating our patients. And so when we started thinking about how do we do this, where do we make the changes, we had to look internally at ourselves first as an organization, because we started doing some outreach meetings. We started doing some information about what to expect with telemedicine, what services we could provide, what was on site, what was off site. And what we found is that whether it was an organization, whether it was myself, whether it was the patients and the agency we serve, that we really started to put people into 3 different buckets. And what we said was that, as we started to teach and as we started to train and look at ways that we can help guide the push towards the future, we put people in 3 different buckets: the oh crap bucket, the oh my God bucket, and the oh yeah bucket. And that really has to do with people's ability and willingness to learn and adopt change. I think that what happens is, in the beginning, many of us were overwhelmed, and there was a tremendous amount of fear in what's going to go on. And I think, what we looked at is that the oh yeah bucket was easy. Those people who kind of embraced, whether it was a person, an employee, a patient, or an agency, says, you know what, we've done a little of this. I think I can handle this. We'll adopt this. We'll get up to speed. We'll do what we got to do. And those were the easy people to adopt in terms of change management. The oh my God people, the ones that had a little bit of experience, kind of were maybe dabbled in understanding about what some of the issues are in terms of outreach and efforts and what could be done. They knew a little bit of telehealth. They did a couple of phone calls and visits, but they needed to take it to the next level. And it scared them to be able to do that. So we wanted to spend a set amount of time and effort based on those. And then the oh crap bucket was probably the most, labor intensive, because it was providers, it was patients, and it was agencies that were so afraid that change was overwhelming, that they were afraid of the obstacles. They wanted to go back to the way things are, thinking, well, we'll just ride this out. We can adapt. Well, the reality is you can't ride this out, as we all know. We had to figure out ways to do this. So, for example, one of the things that we did from a provider's perspective, so that was that we were fortunate because we worked very closely with Metro Community Health Center and Vincent and his team. So we won an FCC award. So we won a couple $100,000, about $480,000, to deploy technology and give tablets to patients and agencies who may not have had the technology with access to internet, et cetera. And so we told our providers, says, listen, if we have patients who are only on telephone for behavioral health and some visits, we have free technology that we have through this grant we're going to give to them. But we need you to step up, and we need you to help us out. And they had a hard time doing that. And we realized it was part the agency, it was part the patient, it was part my provider. So we ended up having a deadline. He said, you know what, by July 13th, I believe is that Monday, I said, if they have not been seen by video, then we have to have a visit. Either we give them a tablet, they come on site and sit in the parking lot with a tablet, they come into the office in a separate room, but we need to see them, make sure they're okay, because as nice as telephonic visits and consultations can be, you're still missing some of that intimacy, you're still missing some of that connection. So we wanted to create that. And that actual push was wonderful for us, and we actually were able to get our telephonic visits down to about 2%. So now we hover about 1 to 2% of all our visits are done telephonically, because some people need it. They don't have the internet, they don't have the access, they don't have the IT capability. But whatever we could do to maximize that intimacy and that connection, we really wanted to make a big difference. When we had our meetings, so as an organization, we had some Zoom meetings with staff and agencies to kind of let them know what was going on. We were sending out regular messages, but we also decided that every week in the beginning, we were going to have weekly meetings for the staff. We just closed the office for that period of time, for that hour, and spent every week talking about, how do we look to recognize where we need to go and go from fear to survival to growth, to kind of create an opportunity for the organization and the providers to kind of feel good about moving forward, and also help support the people around us so that they can feel good about where the change was going to go. What happens is we're the type of organization that we're going to change 10 things at once, because this is what everyone had to do. Realize that 3 things are going to go wrong, 7 things are going to go right. I wish it was that ratio, but it's not always the case. But also anticipate where things are. And so what we told the agencies and told our patients and told our staff is, and this is a slide to kind of support that, is that, you think you're going to make a change, you're going to go to video visits and you're going to adopt this and you're going to train this agency and you're going to have this technology out and boom, everything's going to be wonderful. But, things get worse before they get better. And if we were able to tell our staff and the people we support that, this video visit is going to work because we walked you through it, the next one may not. The next one may be the weekend staff or the covering staff, or this one has to be brought in for this visit because this is a dental, this can't be telemedicine. And if we have this understanding of where the value of change is, but also the duration and the struggles through change, it really makes a big difference for us. So being honest about the uncertainty, being transparent about, what the economic situation is and what you're dealing with, from a provider and an agency standpoint, I think is so important, because as change unfolds, the reality unfolds. We looked at our pandemic plan. Probably, I remember giving a talk to our whole staff. I think it was February, end of February, just when the first couple of cases were coming out. And so in the early part of March, we looked at our pandemic plan. And no, I'm sorry, it was probably the end of the March, because about a month into it. And we all just laughed at our pandemic plan because, we were writing a fictional story with a little bit of knowledge without really understanding what was going to go on. So when we looked at our pandemic plan, it wasn't anything close to what we expect in terms of closing, internet access, sites, providers, agencies, expectation. I mean, we were, way off the mark. So, it taught us, as much as you plan for things to occur and you think you know what you're talking about, the reality is until you're in the grind of where things are, you can't be frustrated with your failure. You have to look at it as a challenge and learn from the failure, and also keep your eyes open to where you are and what you're seeing, because, as we adapt and as we change, we have to realize that this is going to be maybe a component of where we're going. I think the one thing that I've always been blessed with about the IDD patient population is that it always taught me in the beginning, when I got in this field, that it allows you to think outside the box. So the first time I had to do a prescription for a patient who couldn't wear a wrap because he would peel it off, but his skin needed to be covered. How do I do that? How do I order a flu shot when someone is behavioral? And how do I help maybe, look to manipulate the visit to make them comfortable? So outside the box thinking is really part of the bread and butter of what the IDD community is part of. So, as an organization, as a group, we should be the most nimble, because this is what we do on a regular basis. We take, we have this much dollars, we try to put it into this much activities. This is part of what we do. So the more we partner, the more we work together, it makes a big difference. The other thing I just want to share is that, when we consider what virtual care is, I think sometimes we fall into this concept of what I call the iceberg effect of virtual care, that we only think of urgent care and we only think of video visits. And again, I go back to let's open up our eyes, let's open up our expectations of what we think we need now and what we think we're going to need down the road, because better than I do sometimes what the houses can handle, what they can't handle, and what the needs are. So I break down all of telemedicine, all of virtual care into different type of categories. I look at it as urgent care, I look at it as episodic care, I look at it as chronic care, and I look at it as preventive care. And I think all modes of care can be broken down into those 4 different buckets. And then we look at what modalities are available for us. Think about this. We're talking text, we're talking phone, email, portal, virtual reality is part of care. Artificial intelligence, you're starting to see become a big push. Vincent talked about chronic care management, and for us, that was tremendous, because what it allowed for us to do was we were providing about 1,300 visits a month. And one of the magical pieces of CCM in the IDD patient population, as you probably know, is when the parents become Medicare eligible, the patients and the kids become Medicare eligible. So we have 30, 40, 50-year-old kids, well, I call them kids, but patients who are CCM eligible, and their underlying IDD diagnosis helps establish one of those chronic problems. So, we have a potential for a couple thousand patients. And what that did for us during the pandemic, it was allowed us to have all our nursing staff actually be reassigned to chronic care management. But not only that, it made it easy for the group home staff and the agencies to help get the extra care, because someone was talking to them regularly saying, well, you need this, how can I help order this? Where are you? Because they were working from home, they had trouble. So it added an extra layer of care. And so those agencies who aren't involved with that, I would strongly suggest, talking to your health centers about that. Remote patient monitoring, I think, is also extremely valuable, specifically in this kind of COVID era of understanding what someone's oxygen level needs may be, what someone's blood pressure needs may be. So looking at, things from more of a comprehensive approach. Remote patient monitoring in the federally qualified health center world is not reimbursed, but what we're deciding to do is, just like telemedicine, how do we dabble in this to look at how do I get this to the agencies and the patients we support, because there will be value for it down the road. video everyone's familiar with, deployable equipment, and obviously our regular brick and mortar structure, but using it in the right way for us. I wish I could give credit to this person who designed this slide, but what I find fascinating, and we put this up as part of our regular weekly meetings with the staff, is to really pay attention to what is going on now and what's going on in the future. And I almost wonder if there's going to be one of these slides overlaying itself and maybe another slide. I mean, we all dealt with the first wave of the immediate mortality and immediate morbidity, and then the resources. And so now we're really dealing with this third and fourth wave, and we're hopeful that another first wave doesn't come to lay on top of this. And Vincent alluded to this, but we're starting to see cases now where we have abnormal mammograms because the patient, felt something or, didn't want to do it or was nervous about getting a test done. An abnormal, screening test on a Cologuard, which could be potentially malignant. The more you hold that off, the more potential that is. Medications, lab testing, it's all part of this. There's obviously then there's also the issues related to the mental health. I was fascinated by some of my group home patients who some actually did better in the environment because there was some structure of the day-to-day of waking up, doing stuff within the house and having activities as opposed to being out. And I have patients who did really poorly because of the loss of routine, which they normally, as well as the supporting staff and my providers as well. So it becomes a big piece of what we decided to do. This is kind of off to the side, but one of the things that we're proud of is that as an organization, we actually paid for an app and a program called Vita, and Vita Health is an app where we get free life coaches, track calories, track diet, because we want to invest in our employees so that they can be mentally well, physically well, socially well, financially well. It's only going to help the agencies we support and the patients we support. In fact, I have my life coach meeting today, which I'm excited about, just kind of sharing how I did with the diet and exercise over the last week. So really important things for us to talk about in terms of where we think things are for you. Now, what's powerful, and I think sometimes that the agencies don't realize is, your numbers in terms of the amount of patients you support has incredible amount of power. And I think that when you think about what your needs are, and when you look at how do you find paths of least resistance, be mindful of where things are and what your needs are. I've always found that when I was early in my career seeing patients going back to 2000 in the IDD world, is that I really couldn't change the mindset of some of the specialists I could offer advice for and get rid of some of the fear and concern about taking care of patients with disabilities because it was unknown to them. But we were able to make a powerful impact on the staff that supported them to help move those other providers, either choosing different providers or making sure they advocated for them. So there's tremendous power in that. So I think the first thing is that as an agency, when you work with providers and organizations like Vincent's and ours, is you need to assess and address, your digital competency and what's your comfort and what's your confidence. We do kind of surveys where we'll say, well, are you, and this is for patients and staff, is, do you have a smartphone? Do you know how to take a picture? Do you know how to, swipe, left and right and utilize it? Do you have Wi-Fi? Do you have connectivity? What is your baseline understanding and digital competency? And I think that something becomes important to do that. And in fact, we've actually recommended that we have some sort of telehealth captain, either through the agency itself or through the houses or the group that maybe you support. So it allows you to kind of say who's in charge, who can help facilitate, because there's a lot of learn, relearn, and learn again, using technology that is already available for you, because people don't realize that maybe they have the technology, maybe they have the bandwidth, maybe they have the smartphones, maybe they have the capabilities. I mean, between the grants, with the FCC grant that Vincent and organizations have, and other grants out there, there is technology that you have access to. You just have to make sure you ask and you think about it. And then how do we bring this center to the patient? And going back to my earlier comment, is that if you can identify what your needs are, either through the agency or through the group home or for the individual patient, let us know, because maybe we can come up with some creative way to handle that for you to make your lives easier. If I'm asking you to put in more hours with less dollars and less staff, it's a challenge for all of us. So if we can kind of come together, so we have had agencies that come sit down that says, this is where I'm struggling. My staff can't do X, Y, and Z. My cases can't travel here. Our transportation is down with that. What can you do? So one of the agencies we talked about said, why don't we do, blocked dental appointments for you? We'll set up one of the areas for you that you can just come in, so no one else in your is there seeing the patient except our dentist, and there's no waiting room related to this. And so let's create, innovative, hybrid models and pilots that can do that. So if you don't ask, you don't advocate, we may not think about some of these opportunities that we can kind of share and that everyone benefits from. And this becomes about creating opportunities. So think about where they are. So what can be done at the day program? What can be done at the house? What can be done at the centers in terms of what you're close to and what you could work to? We're big fans of having labs come to the house, as you can see from our, obviously most of you work with agencies in the pharmacies that deliver, but are they meeting your needs? Is there after hours delivery? Is there weekend delivery? Like, in this time of need, this is the opportunity where we have to ask for how can we create additional services? And then realize that low tech can be just as powerful as high tech. And what I mean by that is, I had this $30,000 bag of equipment that went to the houses and did video visits. It did stethoscopes, otoscopes. I could take pictures. I could see waveforms of heart stuff. It was unbelievable. It's great. And we still have them and are looking to use them, but you don't always need that type of stuff. A tablet, a phone, some blood pressure kits at the house that you can give verbal information to providers. There's ways to use low tech equipment and have that message and the intimacy and the value of that all be brought together so that we can really kind of get some real uniqueness in the way things are going. So that concludes, my piece. And I'll hand it off to the moderators if there's any specific questions and how else we can share and expand on some of the things. And thanks again for letting me be a part of this.
Okay, hi everybody. This is Deb from CP State. Does anybody have any questions for Scott or Vincent or Jim? And thank you to all three of you. I thought the session was great and there was a lot of really good information, but there's the Q&A box where you can put your questions in and the speakers should be able to see them, or I can read them out to people. Anybody? I want to give people a couple of minutes to type in questions.
Deb, if I could ask a question, Scott, does he have any data on any other states? I thought that California and New York data was fascinating because as part of some of the national organizations I've been a part of, I've always been impressed that New York, and I give CP State and your organization so much credit, kind of leads, healthcare delivery in the IDD world, but I didn't know if some of the other states had some data you come across, Scott.
There are currently, I think, 8 states that are reporting their data publicly. And there's about 15 that are reporting, 8 that you can compare because they're reporting by licensed residential homes. Case fatality rates are the main thing you can look at consistently. They're 2 to 3 times higher per state. They range from as low as maybe 5% for those with IDD to as high as 15 to 18%. So we're still trying to get a handle on maybe why the differences, but it's mainly the ones that are reporting are Northeast. So it's Connecticut, Pennsylvania, Virginia, and there's somebody else, but then the Western states, Arizona, California, Washington are reporting. But that's about it. So far, that's about it.
Right.
Disability Scoop just actually ran an article today saying that four senators are requesting CMS require states to report out their data because many states refuse. And so maybe we can get something done on that level. I don't know.
Yeah, because unfortunately, it's a black eye if the numbers are higher than the general population. And so, which governor, which reporting agency is going to want to share that.
Right.
And so, that's the double-edged sword of the access to information.
Okay. Well, I don't see any questions, so let me just thank you all again for presenting today and being part of our conference. And our next session starts at 2:45, and it's with, it's an update on the CP Telehealth grant and the future of telehealth with the Station MD people. So thank you, everybody. Thank you, speakers, so much. I appreciate it so much. And actually, we got a couple of comments that it was a great session, and thank you. So thank you to all of you, and we'll speak soon. Thank you.
Have a good day, everybody.
Thanks.
you.
Bye-bye.